community for problem suicide that we have within our county. To give you some bearings on this, I believe in 2019, our coroner determined that we had had 84 suicides within Larimer County. There's a study out of the University of Kentucky that basically says that for every suicide on average, there are probably 125 people who are impacted. Obviously, that could be family, friends, coworkers, and by my math, that works out to be about 10,500 people. So this is not a problem that is small in scale. It's unfortunately way too large. But we wanted to talk with you a little bit today about the pillar that the state has set up for suicide safer care and what some of the things are that we're doing in that direction. So I'll start us off, and then Cassie, do you want to introduce yourself now, or you want to wait till we get started?
Sure, I'll go ahead and introduce myself. I'm Cassie Damato. I'm the director of Acute, all of our crisis services programming with our CSU walk-in services, mobile response teams, and our intensive care coordination teams, and our behavioral health consultant teams and integrated care. So like Betty said, we have been working collaboratively with a number of organizations in Larimer County for multiple years now, and have had the pleasure of being guided by Rachel and her efforts with Imagine Zero and the established community work group with Zero Suicide. So really what we're looking at today is, like Betty said, this pillar that was referenced earlier by Sarah Brummett with the Office of Suicide Prevention around how healthcare systems are implementing zero suicide and how we're bringing that to our community in Larimer County, just trying to close the gaps as much as we can as organizations across our county. So it's been a fantastic work group, and we really try to leverage the systems, the healthcare systems, the behavioral healthcare systems, and all the resources that we have available to us in Larimer County to close as many gaps as possible. So that's what we'll do today, is talk through zero suicide and how our systems are implementing those things. So,
I can.
Betty, can you see my screen? Awesome. That means that we don't have a tech issue yet. If so, just play the music again, Deanne. We'll go with that.
Okay. Well, let's dive in and get to some information. I think between Cassie and I, we probably have enough to fill way past half an hour. So we'll try and make good use of our time and your time. First of all, the pillar, which is about access to suicide safer care. Just kind of give you a 50,000-foot view of this. This focuses on healthcare systems and organizations. I would include agencies, and about how they can see improvement in the quality of patient care and the reduction of suicide risk, attempts, and deaths for those within their systems. So this is something that obviously our health system, University of Colorado Health, as well as SummitStone, Health District, a variety of local groups are working towards. You can go to the next slide if you like.
Okay.
Maybe.
I spoke too soon.
There we are. As Cassie mentioned earlier, zero suicide is an approach, a framework that our agencies and our group has been trained in to try and impact suicides within our various systems. It has 7 major tenets. I'll just go through them very quickly. I don't want to get too far into the weeds on this. It talks about leading, which would be a system-wide culture change that's really committed to reducing suicides. Training, which we will talk much more about. Training a competent, confident, and caring workforce. Identifying individuals with suicide risk via comprehensive screenings. Engaging all individuals at risk of suicide using a suicide care management plan. treating suicidal thoughts and behaviors using evidence-based kinds of treatments, transitioning individuals through care with warm handoffs and supportive contacts. And Cassie will be addressing that. SummitStone's doing some really good work in that area. And improve policies and procedures through continuous quality improvement. The Zero Suicide Framework basically came out of some work at the Henry Ford Hospital in the Detroit area, and they saw a great deal of success in reducing the amount of suicides that took place within their health system. And so they have, in a sense, taken that model that worked well for them and are training various other agencies and groups, hoping that there's value in it for them and for us, of course. One of the things that they talk about is that 83% of those who die by suicide have seen a healthcare provider in the year before their death. Interestingly enough, only about 29% of those who died in the past year actually saw someone within outpatient behavioral health. So the contact that folks are having could be with a primary care provider, a radiology clinic, oncology, any part of the medical healthcare system. So it's based on the idea of we have lots of opportunity to reach people and perhaps intervene in really helpful ways before people are lost to suicide. So Cassie, do you want to move on and maybe address QPR a little bit?
Sure. And I think one thing that really stuck out, for me for zero suicide is we have this framework of care that's called zero suicide. And you've heard the statistics that Sarah spoke to, that Lori spoke to, that Rachel spoke to, that, that we've all been made very well aware of, and wondering, wow, that is a lofty goal, to aim for zero suicides. But what really stuck with me through all of the trainings and the years of doing this work is the reiteration of what other goals should there be. We really should be aiming for zero suicides in our community, even though we know that there's a lot of work ahead of us, to get to that point. But that's really what stuck with me. And I think this first piece of training that really sticks out for the work that SummitStone has done, and then UC Health also has done a lot of work around QPR, is what we call as a gatekeeper training. So question, persuade, and refer is a training that's offered in both of our systems. SummitStone has provided QPR training to, I got data yesterday, 870 people since we've picked up zero suicide. Wow. And the beauty of this training is that it's not just for healthcare systems. This is for anyone. This is how really what we equate CPR to, of saving someone's life in the physical health world. QPR is really the CPR of behavioral health. And we are able to offer that through our organization and do so continuously. So I shared a brochure or flyer with Deanne that hopefully we can get in the chat, or at least get connected somewhere with this resource. But anytime you reach out to SummitStone, you can ask for this training. If it's with, we've trained different employers, we've trained the workforce center, we've trained schools, we've trained different, primary care facilities. So there's just, it's a wonderful training that really generates some awareness around the prevalence of suicide and what to do whenever someone might relay some information for you, or just relay some education around what warning signs there are, because suicide affects, doesn't just affect one person when it occurs. It impacts an entire family, community. Our entire nation is impacted. And if we can generate some common language around what it is that we're looking for, and then how to connect people to resources, that is a really wonderful training that we've been able to adapt, that zero suicide really drives home and identifies for anyone in any system or in any kind of community, that this is a helpful tool for. So we've implemented this for every one of our employees onboarding at SummitStone as part of their onboarding. Doesn't matter what role that the individual plays in our organization. So that's one piece of the training aspect and training tenet that Betty spoke to. Betty, do you want to speak to anything else around QPR?
I would just add that QPR has been very valuable within our system as well. We have focused within UCH on trying to train our internal employees that are in gatekeeper kind of roles, not just clinical roles, but front desk people, folks that check you in when you go in for an appointment, nurses, folks in lots of different roles who might be in a position to be very helpful to somebody who's in a bit of a crisis. So we found that to be helpful. We had a grant that supported having one of our staff do these trainings internally, and I don't think we hit 840. I think we probably were more right around 700, but we are continuing to offer this internally for our employees as well. It's been very, very valuable.
Great. And a few other tools that we'll share with you. We won't go into in-depth detail for today, just as Betty said. We only have a little bit of time to talk through what Zero Suicide calls as a marathon of an implementation. So today we have a little bit of time to just highlight what our systems have done. So one of the other pillars with the CNC is really around access to lethal means and means reduction. So that's a training. The counseling on access to lethal means is a training that we've adopted at SummitStone and at UC Health. I believe you all have as well as a mandatory training for anyone who's hired on in a behavioral health role with SummitStone. In addition to counseling with access, our collaborative assessment and management of suicidality. So that's CAMS, and that's actual treatment of suicidality versus other treatments like CBT or DBT that we'll go over. But these are two tools that we've adapted that are supported through the Office of Suicide Prevention, and Sarah had spoke to earlier, but there's some funding that comes through the Office of Suicide Prevention for these specific trainings. Another tool that we've implemented is the Columbia. It's basically a standardized screening tool that anyone who touches a service in our system are asked very direct questions. So that is an important piece of the pathway. The suicide management plan that Betty spoke to is identification. So asking the right kind of questions, identifying, and then getting people the care that they need. So this is another tool that is adapted into every service that we provide. Betty, I'll kind of bounce it back to you if you have anything on these three tools.
I will just say that we are in the process of incorporating the Columbia scale into many of our assessments within the UC Health system, within the behavioral health end of things, obviously, and also just in reference to the CAMS. The state has been very helpful in supporting some trainings that are not just trainings being utilized by our clinical staff or SummitStone staff, but I know one of the trainings that I went to for CAMS, I believe, was opened up to like 100 people. And so there are several providers in the community who are trained in this as well and utilize it with their clients.
Absolutely. And another tool that is a really important piece of the zero suicide pathway of care is really sound safety planning. So as providers in systems of care or as individual providers in the community, an important piece is not only to screen with a service to provide a treatment and evidence-based treatment, but then also at the end of a session, consistently safety planning to ensure that that someone isn't disconnected from the work that happens in a session. So we have worked collaboratively with UC Health and some other organizations in the community work group to try to establish a community safety plan. So a template that has a common language between the systems of care. So one safety plan for SummitStone doesn't have to look one way, and then if they're discharged maybe from Mountain Crest, we have the same language. We actually have the same template that we can share information as long as we receive releases of information and are able to best coordinate care to where people do not feel like they're jumping through various systems and have to redo the work maybe that they had done when they had touched another healthcare system. So it's just another way that we're looking at how are we closing the gaps in Larimer County and how are we best collaborating as a community and as systems of care versus into very individualized practices and approaches. So this was based off of much of the CAMS language. And this is just a tool that I think that we're really proud of, pairing the forces, you know, in our community to bring this together, and being driven through some of the tenets with Office of Suicide Prevention.
Okay, let's talk a little bit about how UC Health got involved in some of this. Way back in 2016, which feels like a lifetime ago, honestly. Maybe it's just because of how 2020 is going. Our system did what's called a community health needs assessment. And I know that's a mouthful, but basically what they did was they worked to identify problems within the community that they really wanted to make as a priority to address. And two of the ones that they came up with were suicide prevention, which is a very clear priority, and also substance abuse treatment and prevention. So in June of 2016, they sent a team of, I believe, 4 of us to a Zero Suicide Academy, kind of a training that was underwritten by the state and attended by folks from all over, probably including Cassie and her team. And from that, learned a lot about the Zero Suicide framework, how other groups had implemented that within their health system or their university health systems and agencies, and kind of went back to our own agencies and systems to try to think, how can we implement this? Right about the same time, we also were getting involved and connected, in a sense, with the Imagine Zero Coalition, which of course is now tied within the Alliance for Suicide Prevention. So basically, a lot of groups coming together, seeing a common goal, really making this a priority, and forming and supporting this as a community coalition. So that's a little bit of the history about how we got involved. If you want to go to the next slide.
Did it go for you?
Got it. Thank you, Cassie. These are just a few of the projects that we've been involved in, and as you'll see from what we've already talked about and what Cassie's going to address, we have a lot of things in common. Programs that we have each implemented in our own way, sometimes collaboratively, sometimes on our own, but some things that we feel have been helpful. Cassie talked quite a bit about the gatekeeper training, using QPR, the question, persuade, refer training, and that has been really, really helpful. We've trained a number of our employees, various departments within the hospital, and the feedback we've gotten from that is people feel much more comfortable talking with someone and kind of picking up on things that they can identify that are somewhat worrisome, and talking to that person, helping connect them with support. And often that is not a skill that they felt comfortable with previously. So it's been a really, really helpful training. The Lethal Means project had to do with making some things available, largely through our emergency department. And Cassie, I think you guys were involved in this as well. And this would be gun locks, things like that. If someone is high risk and they obviously have easy access to guns or weapons, there's obviously a concern there. So that was a project that was involved. Inpatient and crisis assessment follow-up with the Rocky Mountain Crisis Partners. This is a little bit of that warm handoff we were referring to earlier, where if someone is in crisis or is discharging from the hospital, say, and needs kind of a supportive follow-up, one of the things we could do was to get them on the phone with Rocky Mountain Crisis Partners, which is available 24/7, and have them make contact, and then they could follow up with them, see how they're doing, if they've had any trouble connecting to care, those kinds of things. CAMS and safety planning, of course, Cassie just addressed. And the co-responder program, which again, are several community agencies coming together to identify this need and basically come up with a mental health provider, behavioral health provider that works within the law enforcement framework in a sense. And sometimes we'll go out on certain calls that seem behavioral health in nature, or where somebody might have some concerns in that area, and they may go out with the sheriff or with the police or whatever to try and intervene in ways that are really helpful to the situation and probably more suited to what that person needs than just law enforcement responding. Cassie, feel free to add to that in your things. And then lastly, just the support of community projects. These are things, again, that as a community have been put on in recent years. Frank Warren, who does the Post-Secret books, came and did a presentation, and several of our agencies had a lot of support available. We tagged on a QPR training afterwards, so we were able to train some community members as well. Randy Bacon's Stories of Suicide Survivors, that was just last year, a series of photographs and some narrative from folks that were impacted by suicide. Teen Self-Care Fair, which Imagine Zero has done a wonderful job of putting on the last couple of years, helping teens get some skills, some resiliency skills, some support, some ideas on how to manage feelings, problems, conflicts, all kinds of things. What we're currently working on is we're partnering with the Alliance to conduct some focus groups and to get some feedback as to suicide-related care. For instance, if someone has come through a hospital system, what was helpful? What wasn't helpful? What would you suggest? What would have been more helpful? Those kinds of things, so that we can fine-tune the kinds of treatment that we provide and make sure that we're doing what's really needed. So that is underway right now. And I'm sure I've missed a few projects along the way, but those are the main ones. So Cassie, I'll turn it back over to you for the pathway.
Awesome.
And I just want to apologize for interrupting, but we do have about 5 minutes left until the end of the session to kind of wrap up. So if we can wrap it up in about a minute and then allow for questions and answers, ladies, that would be great. Thank you.
Sure. I'll move swiftly here. So like I said before, this project is a marathon of an implementation, and the pathway that Betty had talked about is really creating a sound journey for anyone who is screened and identified within systems of care. So essentially, this is an overview. We don't have a lot of time to dive into the details, but really looking at screening. Building into our EMR was a huge component for SummitStone. So we were working with our IT systems to ensure that we have the right information where it needs to be, and then just connecting people to the right services at the right time. SummitStone has a variety of different programs throughout the county, embedded with law enforcement, like Betty spoke to, embedded with hospitals, embedded with inpatient facility, embedded with primary care clinics. So really for our system, it was about how do we soundly support someone through the transition of care. So I'll quickly move through that. I really love this quote: ordinary therapy in the hands of good clinicians is magic. So I think that just reinforces the need for this suicide care pathway. So these are just elements that we highlight in our system. Caring contacts, I want to speak to a little bit of this, so I'll push the minute that I have, but it's important to include those with lived experience in our process and in our care pathway. So we have peer specialists who are automatically reaching out to anyone who is identified as high risk. So really trying to engage someone in a way that's warm and maybe less treatment oriented and very personal. So we have caring contacts that we can refer someone to receive multiple between the various levels of care in our system. And these are all of the elements that SummitStone has really worked through. So I won't go through each of them, but it's been a huge project, and I think our system, I'm just really proud of the work of the work group at SummitStone that's really been led by Stephanie Madsen-Pixler, our director of community-based services, in getting a team on board and the leadership investment from an organization to recognize that overall, all the tools that we use, the clinical implementation, that we have this team that is really focused on making these significant changes in a pretty big system. We have a system of almost 400 employees that we're making the changes across the organization. So not to go into all of them, but those are just some of the highlights that I'd like to point out. And to wrap up, since I know we have a few questions in the chat as well, what's most important, I think, that we share today too, is that there are a number of resources available. We have phone lines, we have our local phone line, our local crisis line, we have the statewide hotline that you can call or text to. You have the CAC at UC Health. We have the Connections COVID Warm line that SummitStone is actually partnering with. That's not a crisis line, but more for support in this COVID environment. We received some FEMA funding for, so that is on here as well. We have the ability to walk into one of our urgent care. We have the ability to respond mobily in the community 24/7. We have our co-responders that Betty spoke to. There's respite at North Range that we can refer to, and our CSU, the residential units, and then Mountain Crest, our inpatient unit. So there's a number of resources that through the QPR training in the community that these are the resources that we connect people to, knowing that there's always someone available at any time to reach out, even if you're not sure where to go. There's a number of different kind of access points for anyone who needs the help in our community. So that was really brief, I feel like, but we made it through, and now we have a little bit of time for questions, hopefully.
Yes, it looks like there's two questions that hopefully we'll be able to get to, and then I'll do a little closing words. So Courtney, where did it go? Courtney said, I am a direct patient care provider. Many of the clients that I work with have had life-changing incidents that have potential to cause both isolation, physical and emotional, and depression. However, if I document anywhere that the client may have suicidal ideation, they are often disqualified for continuing care needed. How do I address these problems with further harming many patients' recovery?
Cassie, I'm going to let you have that one.
It sounds like the fear is around documenting for reimbursement for payers. Is that right?
And Courtney, feel free to ask if you want to jump in there too.
It's a great question.
Mm-hmm.
So I'm a physical therapist, and I am often treating patients after I'm a neurological specialist. So I'm often treating patients after traumatic brain injury, spinal cord injury, stroke, and in an inpatient setting. If that client needs continued care in form of going to another residential care center, I can't put in my documentation that they are depressed or that they are having any, like I said, any suicidal ideation, because then that residential care center will not accept that.
So I think that's the beauty of having all of these resources available to you, because you're not a service provider. You're not a behavioral health service care provider. So making an appropriate referral to someone who is, or a crisis center or emergency services, I think that you're referring to the behavioral health care providers who will then take that, that further. So your screening is one element of getting a person to the right level of service. So I think that that's one approach that you could take, is that you're screening. If they're disclosing to you that they have possible suicidal ideation, you don't have the full ability to screen and fully assess, then you're refer to someone who does, and that can live in their system. That's where our documentation can be protected, whether it's SummitStone or an individual provider, depending on their insurance. That's what I would say to that for you in your position. Okay.
Thank you. And then just maybe one more quick question. Adam said, thanks, Betty and Cassie. Question, do you also screen for risky substance use as a risk factor to suicide in addition to the Columbia? If so, what does this look like?
Yeah, that's
Thank
a
you.
great question.
Yeah, I
Maddie.
would say yes, we definitely do. There are multiple risk factors that can put somebody more at risk. You know, obviously the Columbia is going to screen for a certain level of suicidality, but it shows kind of one aspect of things. It's also important to look at not just substance use or availability of substances or those kinds of things, but also socioeconomic situation. All of those things play a role, especially right now in our economy and COVID and everything else. So I think one thing that we have noticed within our outpatient clinic is more use of substances right now during COVID. I don't think anybody would argue that, honestly. And I think that substances can maybe make somebody a little more at risk, as they're more likely to take action that maybe they would not take as freely without all of that. So I hope that answers your question. It is something to consider, certainly, and we would want to know that information as part of making a decision.
Absolutely.
So much. So we're going to have to wrap up. Thank you, Betty, Vail, and Cassie Damato for speaking with us today. We look forward to continuing the conversation around suicide and safer care. If you are interested in receiving a training and or joining a work group to be involved in next steps, please fill out the post survey where we will gather your information and follow up via email. The post survey also assists us with grant funding that keeps all of our programs free. So it would be much appreciated if everyone was to quickly take it at the end of the symposium and give us any feedback you may have. Thank you again so much for attending this session. Please refer to the ASP website for information on the session following. All participants are now welcome to return to the main room to join for our optional guided break, and then we'll start the next session. I believe the next session starts at 11. So thank you for joining. Also, a real shout out when it comes to resources. I know we're talking about suicide, but you don't have to be suicidal to reach out to all of those resources that are available. The crisis line, it's for any kind of crisis. So just know that and have that, and thank you so much. Oh, there we go.